We will begin with our next session on HCC, Changing Clinical Perspectives. For that, we would like to invite on stage our moderators, Dr. Ayesh Rivenu, Dr. Prabhat Sharma, Dr. Dipanjan Panda, Dr. Gagan Saini, Dr. Shoket Mahmood Chaudhary, and our chairpersons, Dr. Deepak Pandey, Dr. Sumita Shrestha, Dr. Pavan Hanchanale, Dr. Sachin Gupta, Dr. Arun Gupta. And for the first talk on management of portal hypertension in HCC, we would like to invite on stage Dr. Shiv Sareen.
So I would request all the moderators and chairpersons to please come onto the stage. And I would like to invite Dr. Sareen.
Thank you, Dr. Arora, and it is a pleasure to be here. I was very happy to see my teacher, Professor Nandi, and my all other colleagues, Dr. Rawat, and thanks Ashish and Praveen for accommodating me. I am bringing you something which might be of interest, but for me it is an area where future guidelines are needed, and I thought I'll share this concept with you. I have nothing to disclose. I will just tell you today, this is a data we published from 11 centers in India, that today the commonest cause of liver cancer is diabetes. Out of 100, 39 are diabetes. This is a very important slide and I want you to walk with me. In cirrhosis of liver, you have injury, you produce DAMPs, you have Kupffer cell activation, stellate cell activation. An activated stellate cell produces VEGF, PDGF, also several cytokines and extracellular matrix. You also have an injury of L6, the sinusoidal endothelial cells, which lose fenestration. And as soon as the endothelial cell is damaged, you have platelet aggregation. Now, this leads to an increase in von Willebrand factor, which is subendothelial, and ADAMTS decreases, and you have platelet clots. This is cirrhosis, and in this process, you have increased vascular resistance, and you have fibrosis and angiogenesis, and this is a hypoxia. Now, when does this hypoxia changes the angiogenic switch from portal hypertension to HCC? Please bear with me. So, when you have hypoxia, you have expression of VEGF receptors. VEGF comes, you have initiation of PI3 kinase and MAP kinase, and you also have development of HCC. This is one part. Now the second part is how platelets cause this. So you release PDGF, you have change in the environment by IL-6, TGF beta and hepatocyte growth factor. What I want to say that portal hypertension is an earlier stage of liver cancer. So everybody who has liver cancer, especially cirrhotic, has portal hypertension. How do you manage and diagnose? So we always believe anybody who has platelets of 100,000 or less has portal hypertension. This is not true in HCC because platelets increase in HCC. So you will be underdiagnosing CSPH just by platelets. Second, patient has portal vein invasion. You will be having HVPG inaccurate. Third, your SSM and LSM, all of them will be inaccurate. So diagnosing CSPH in patients with HCC is inaccurate. Therefore, you need endoscopy before starting treatment, and you then have to decide this guy is primary prophylaxis or secondary prophylaxis. So, von Willebrand factor single agent of more than 315% will give you in HCC a portal pressure above 10, very reliable. A ratio of 1 Willebrand factor antigen to ADAMTS13, which breaks down platelets, will predict you HCC size and metastasis, and I'll show you the data. I'm not showing you data of CT volumetry and esophageal varices size. If it is more than 1.9 millimeter on CT, this guy will bleed. Now let me show you the ratio. If it is more than 5.5, this correlates with alpha fetoprotein. Higher levels, higher the ratio. Higher the ratio, more is des gamma or PIVKA. Higher the ratio, more L3. And of course, the platelets, you will see when the ratio is high, we would think platelets should go down, platelets go up. So, how do you manage variceal bleeding, primary and secondary? Which one is good, EVL or beta blocker in primary prophylaxis? This beautiful study, which we started in 2014, could never finish, but published in Gut from China. The red is propranolol, the blue is EVL. People who received EVL did better. Cumulative incidence of bleed and cumulative incidence of esophageal variceal bleed in child A and B and child C and D. So in A and B, band ligation is superior, but in child C, they are equal. Survival, in child A and B, EVL is better, and in C, it is same. So the message is, if you have an HCC with child A or B cirrhosis and portal hypertension, EVL as of now is better. Now you have a patient who has massive ascites and has a high risk of varices bleeding. Should I do TIPS or no TIPS before TACE? I can't do TACE. So should I do TIPS? And this beautiful score, VASIA score, I want you to remember, very easy. V is vascular invasion, A is ALT, C is creatinine, extrahepatic metastasis, yes, is 1, and AFP is high. If there is a score grade 1 and 2, two things out of this, the survival is 25 months for grade 1, for grade 2 is 15 months. So if I do TIPS, my patient with ascites will still survive. If it is grade 3 and 4, means he has 4 out of 5 factors, then survival is 9 and 6 months. So which patient will I do TIPS before TACE? If my patient has 2 out of 5 risk factors. So I prefer doing TACE before doing TACE. Now patient has come with variceal bleed. A patient who has cirrhosis and variceal bleed should survive 3 years, but cirrhosis and HCC will survive 5 months. My job is to make 5 months into 38 months. He should at least live 2 years. TIPS and glue are both useful. I'll go to the secondary prophylaxis. Patient has bled. How do I prevent rebleed? So TIPS was compared with non-selective beta blockers and EVL. Blue is TIPS and then is the combo therapy. Now patients having rebleeding, less with TIPS, freedom from rebleeding less, survival overall, and this is a way that the progression to survival or disease is better with TIPS. So TIPS helps us in 3 ways: acute bleeding, ascites, and allowing TACE, and preventing rebleeding. A data of 19 studies of about 900 patients. If the patients have more portal vein thrombosis, TIPS is better. We are worried that the thrombus may go and settle there. No. TIPS resolves bleeding and ascites, no serious complications. HE is there as otherwise, and patients can be actually prevented from LT or can be taken for LT. Now, there are 2 other areas: systemic therapies and new perspectives. What is the influence of different therapies? TACE and TARE increase portal pressure. Must give beta blocker beforehand. We always think that the liver stiffness above 25 is bad and it is CSPH. Remember, liver stiffness of 16 is bad enough, and spleen stiffness not above 32 but 22 is enough, because you will do a locoregional therapy and patient will have either post hepatectomy failure or post TACE liver failure. An infiltrative HCC is worse. There is more rapid progression and more chance of AVB. Now, lenvatinib, it is routinely used like a iron pill. Let's see who is likely to bleed on lenvatinib. A patient who has got portal vein thrombosis, has a high CTP score and a low platelet count. These are high risk patients. 7% of them, but it can be very high also, will bleed significantly. So when you are having a lenvatinib patient, remember PVT, high CTP and low platelet are taken care of. Now we have several drugs. Sorafenib decreases portal hypertension, but risk of bleeding increases and decompensation. Lenvatinib increases portal pressure, risk of bleeding and encephalopathy. A plus B, Atizo and Beva, there is no data on portal hypertension, but risk of bleeding due to Beva increases. And Stride, tremelimumab and durvalumab, we have no data as of now, but the risk of bleeding may not increase. My preference is still A plus B rather than tremelimumab, because they are very expensive. Now, what is the risk of bleeding on ICI? So, IMBRAVE, where acute variceal bleed was noted carefully, if the patient has portal vein thrombosis, 14%, but your routine patient, no PVT, risk is only 1%. Workup for portal hypertension by doing endoscopy is necessary. Primary prophylaxis of every patient, even with small varices, start beta blockers, and if the patient is likely to survive 2-3 years, do it every 6 months, and we may wait for new drugs without Beva. Now, if the patient has bland thrombosis, chlorodic portal thrombosis, there is no enhancement, and the patient is on anticoagulation. Should I stop anticoagulation before bevacizumab? It's a question. He's on any of these oral drugs. Well, such patients should be switched on to low molecular weight heparin. You do the EVL in these patients. Beva must be stopped in these patients, and we should continue with possibly a low molecular weight heparin. Monitor liver stiffness. You should try to bring it to less than 25, preferably less than 16. Now, anticoagulation was generally considered it will prevent development, improve survival in HCC. It was my thought also, till I read this very interesting paper that there is no benefit of giving anticoagulation to improve survival in patients with HCC. What do we do? If there is a variceal bleed on Atizo Beva, we will stop Beva and then try and give coagulants for some time, including Trenexa. Beva delays EVL ulcer healing, and therefore you may not be able to control the bleed. What we do, that we will give Atizo and then we will wait. If the patient has already received the two, then we will wait for 1 week and then we can do EVL. And after surgery, certainly Beva has to be stopped for 4 weeks. This is one of the first papers to say whether TIPS can be done in HCC with portal vein thrombosis. This is 2004, and they were successful in 73%. Today, PVT and HCC, you can place TIPS in nearly 95, 9 out of 10 patients. Beta blockers, are they beneficial in preventing HCC? For sure, yes. HCC incidence is decreased on beta blockers. But propranolol may not be beneficial, maybe timolol slightly, nadolol slightly, carvedilol for sure. This slide shows you a large database when they were giving the lipid soluble beta blockers non-selective like carvedilol or so there is a benefit in preventing development of HCC. In last 2 or 3 slides, I'll show you that a patient has come and you do a CT scan. A CT scan shows the esophageal intramural vessel diameter. It's not generally measured but can be measured with it. If it is more than 1.9 millimeter, as I showed before, this guy will develop varices in 3 months time. If the patient has more than 3 millimeter, then the patient may bleed, and if it is more than 6.8 millimeter, the patient will develop encephalopathy after your tip. So remember, go to the radiologist and measure esophageal intramural vessel diameter. What we do, endoscopy in all cirrhosis with HCC. Platelets, even if they are good, doesn't matter. LSM, even if it is less than 15, we will do it. Everybody who has an LSM above 20 or platelets 100,000 and less will have beta blockers. Splenic stiffness, if not portal vein thrombosis above 50, we will give beta blocker. All those undergoing any of the loco-regional therapies or TKIs or ICI will get beta blockers. Ascites needs to be controlled. This is just to show you, this could look like a bland thrombus, but this was a tumor thrombus and patient had high PIVKA. So I'll give you my last message. HCC generally is a later stage of cirrhosis with portal hypertension. So everybody with portal hypertension, remember to look for HCC. Assess patients by endoscopy, platelets of course, and a ratio of 1 Willebrand factor to ADAM-TS13 of more than 5.5. Manage prevention of development of HCC by beta blockers and statins. Primary prophylaxis as of now, EVL is superior. AVB, EVL plus beta blockers versus TIPS. TIPS is superior. TIPS allows loco-regional therapy, improves survival. Use the VASIA score, which is vascular invasion, ALT, creatinine, extrahepatic spread, and AFP score. TKI and ICI both can increase portal pressure, precipitate bleed, EVL ulcer, healing can be delayed. Give BEVA before EVL, not after EVL, and use beta blockers in all. And with this, we request you to join Hot Topics at ASLD November 15th and 16th. Thank you for your kind attention.
Professor Sarin, if I may ask you one question, sir.
Please.
Sir, we know that lenvatinib not only it also causes a lot of systemic hypertension. So that also can be one of the cofactor. Secondly, sir, in atezo-bev, if you stop bev, only atezo, most of the trials did not show any evidence of single agent atezo. So maybe those patients for which bevacizumab is either contraindicated or later become contraindicated, you change to durvalumab with tremelimumab or maybe nivolumab, ipilimumab, sir. I would like to know your
Totally agreed with Dr. Dipanjan. If you are unable to give BEVA, there is no point in giving single agent. If you can give after a week, that's all right. If after 2 weeks, because 2 or 3 sessions, the varices become less, you can give BEVA. But if you can't give it, change it to either Nivoli or to Stride, definitely.
Thirdly, sir, if there is a tumor thrombus, will it be an contraindication for BEV? Because atezo-bev was used in BP4. So I
Not
think
at all. They are good for.
They are good.
They actually work very well. Both the Stride as well as A plus B, they work very well with tumor thrombus. Very well. So.
Thank you, sir. So we will have questions after the conclusion of session.
For the next session on role of liquid biopsy in HCC, we would like to invite Dr. Monica Jain.
Good morning. At the outset, I would like to thank Dr. Anil Arora, Dr. Ashish, Dr. Praveen and their team for giving me this opportunity. My talk is on role of liquid biopsy in HCC. Are we ready for prime time? We all know HCC is the 6th most common cause of cancer globally. It is the 3rd leading cause of cancer-related death in world. and we have high incidence in Africa, Asia, and some other areas. How do we diagnose HCC at present? We go by radiology. We check the peripheral markers, alpha fetoprotein, PIVKA, and biopsy if required. But as we see, alpha fetoprotein lacks sensitivity and specificity. PIVKA2 is also, although less sensitive, but it's more specific. Imaging has got a limitation if the lesion is less than 1 centimeter, and biopsy is invasive and risky. So, does liquid biopsy fill this void? Let's see in next 10 minutes how do we stand. Let's understand what is liquid biopsy. This is basically a minimally invasive test using blood sample which detects tumor-derived material. That can be circulating tumor DNA, circulating tumor cells, exosomes, microRNAs. It provides real-time tumor information, and its role has been seen in breast cancer, lung cancer, prostate, colorectal cancer, and now we are having lot of data in HCC also. What are circulating tumor cells? They are actually the cells which are shed from the primary tumor into the bloodstream. The detection method, how we can pick it up, is by cell search, microfiltration, and immunoaffinity. It provides insight into the metastasis of the tumor. Coming next to circulating tumor DNA. What are they? They are small DNA fragments which are released by tumor cells. They contain tumor-specific mutations. This is a very important information which we can get from these DNAs like TARE, telomerase, reverse transcriptase. We can get information for tumor protein p53, catenin beta 1. All these mutations can be studied in this material, and this is used for prognosis, therapy monitoring, and predicting drug resistance. Then comes the microRNAs. These are short, non-coding RNAs which regulate the gene expression. They are, we all know, are dysregulated in HCC about microRNA 21, 122. We have lot of data. They are stable in serum, and probably they are the potential biomarkers which we can use in HCC. Lastly is the exosome or extracellular vesicles. They are small vesicles carrying DNA, RNA, and protein. They reflect actually the tumor biology. They can serve as a diagnostic and therapeutic tool in management of HCC. So the role of liquid biopsy in HCC has been defined in early diagnosis, prognostication, minimal residual disease monitoring, tumor monitoring, therapy guide, and to show the recurrence or metastasis. Let's see how the data supports these information about circulating free DNA and circulating tumor cells. This is a utility of liquid biopsy. We have a systematic review of 112 studies in which the analysis was done for detection of HCC. So the conclusion was that CTCs and cfDNAs might aid in monitoring and prognostication of HCC. Another data of 36 studies which showed that this was done for diagnostic as diagnostic modality in HCC, and the conclusion was this may be a useful marker, but unfortunately the studies lacked standardization. Then came circulating DNA as a prognostic biomarker in patients with advanced HCC. This was a translational exploratory study from Soremic trial, and the conclusion was that this may have a prognostic value also and predict therapy response, because we can do a lot of genetic studies with this material. Then circulating DNA methylation marker for diagnosis and prognosis of HCC. Methylation is a technique to pick up the, if we take out the DNA material, and methylation of that can be used as a specific marker to make the inference. So this may have a utility in diagnosis, surveillance, and prognosis of HCC. Then we have circulating tumor cell expressing epithelial mesenchymal transition. This is an important step in HCC when we have cells which are shed inside the blood vessel. The epithelial cell, they transform into mesenchymal cell, and the amount of this mesenchymal cell and the cancer stem cell, if we take out that and if we can quantify and make the measurement, that can help us to take that we can this can predict increased risk of early post-operative recurrences. Then role of cell-free DNA for HCC, again a systematic review. The inference was this has got a diagnostic accuracy in detection of HCC. Again, this was not in Asian population. We have data in Asian population also. This also showed that this can be used as a prognostic marker and is negatively correlated with the survival. About microRNAs also, we have lot of data in which we have seen that it has got a superior performance in diagnostic armamentarium of HCC as compared to other markers. Then we have that it can detect it better, and some of the mutations which are very important as we say for therapeutics, that can also be picked up by these microRNAs. So how do we differentiate tissue, how do we rate tissue biopsy versus liquid biopsy? If we see liver biopsy, the pros are high accuracy, access to the spatial information, assesses stage and invasiveness, comprehensive genomic analysis can be done. But the cons are it's invasive, pain, bleeding, risk of track seedling, and misses heterogeneity. This is a very important concept which is picked up by liquid biopsy. So in liquid biopsy, we have, this is non-invasive, captures both tumor and tumor microenvironment, real-time monitoring, and serial testing is possible. So what are the clinical application? This detects early detection in high-risk population. Prognosis and recurrence monitoring can be done. Treatment response and resistance tracking can be done by liquid biopsy. Although no large standardized data is there on liquid biopsy for HCC, multiple ongoing clinical trials are there, and integration with imaging and AI is coming up in a big way. We have a data from Dr. Mohammad Raila's group in which they did validation of multiplex hypermethylation based blood test to detect hepatocellular carcinoma. This was a prospective case control study in which 588 patients they were studied, and this test could pick up early stage, intermediate stage, and late stage. In the percentage you can see 87, 91, and 94%. And the test correctly identified 92% of the patients who were alpha fetoprotein negative. So combining AFP with MHSH test increased sensitivity to almost 96%. The challenges and limitations are sensitivity and specificity issues, lack of standardization across lab, cost, technical barrier, and requires validation in large trials. What are the futures? We can have multi-omics, genomic, transcriptomic, proteomic, metabolomic approaches in this diagnostic approach, and we can combine different biomarkers, and integration into precision medicine is required. So liquid biopsy is a promising tool in HCC, useful for diagnosis, prognosis, and monitoring. It needs further validation before routine use. Thank you.
Thank you, ma'am. For our next talk, I would like to invite Dr. Joy Varghese, and the topic is Unmet Needs in Prognostic Markers for HCC.
Good afternoon to all. At the outset, my sincere thanks to the Professor Anil Arora and all the organizing team members. See, in liver cancer, 90% of them will be hepatocellular carcinoma. Only 10% will come as a hepatoblastoma, cholangiocarcinoma, or mixed tumor, etc. If you take the global incidence, HCC will be the fourth common cause of the cancer mortality-wise. Unfortunately, in developing countries, the prevalence of HCC is more than the developed nations. With available Indian data, it shows HCC is the 10th common cause of mortality among the cancer mortality. Regarding the prognosis of HCC, what we know in the clinical parameters wise, we can assess the prognosis. Example, I can say the male or more, the prognostic wise, the outcome will be bad than the female gender. Morphologically, based on the well-differentiated tumor, moderately and poorly differentiated tumor, that's outcome. And the biochemical, there are tumor markers are available. Nuclear medicine indicators, we can say PET scan, the FDG uptakes are there. It also indicates the poorly differentiated carcinoma of the HCC and histological also. So, other than that, there are the newer markers are there. Just I will once again highlight what are the clinical indicators of prognosis. It is applicable for all the HCC patients whenever we are seeing in practice. Male gender, outcome will be poorer than the female gender. If the patient comes with the symptoms, of course, outcome will be poorer than the asymptomatic. If the HCC patient have the associated other comorbidity, outcomes will be poor. And young people, so we thought elderly groups, but if you are not young people, there is the outcome will be the poorer that thing. The morphological prognosis, the imaging wise, if you take larger tumor, and if they have already invaded into the vascular structure, or the bile duct invasion, and in the absence of capsule, and in MRI scan, if it shows the intracellular fat accumulation, that's why we can prognosticate the outcome. Whatever the therapy, either we are going to go for the curative therapy or the different forms of palliative therapy, either loco-regional therapy or the systemic chemotherapy. So before that, we can assess. Biochemical indicators, we are regularly using alpha-fetoprotein, PIVKA2, and the AFP-L3 in the certain cases. Of course, all the data shows combination of the biochemical therapy will be the better than the single biochemical markers. What type of combination? That's called BALD score. In a BALD score, they incorporate all the three, and most of our HCC patients are cirrhotic. So they incorporated bilirubin as well as the albumin. It is not widely used, but whatever the available literature shows, this will score over the rest of any single marker while assessing. So this BALD score wise, and the next time there are BALD 2 will be the much better than the BALD 1. So BALD 2 is the logarithmic score. BALD score initially when they formulated in Japan, so that time they used a CTP scoring system. They put a values 0, 1, 2. That's why they formulated. But the logarithmic score shows the much better outcome. The tumor recurrence. So whatever I have mentioned, few things, it's not always practically applicable because based on the types of therapy we are choosing, that prognostic marker also will vary. For example, alpha-fetoprotein, after the TACE or RFA, it will show the decreasing trend, means we can say the tumor response is there. At the same time, if you are applying the PIVKA2 after the loco-regional therapy, it is not showing the much reduction, and sometimes it will show the increase in the value, but it will not well correlating with our CT scan after the loco-regional therapy. So there are the pitfalls in the biochemical markers. So we have to choose to assess the prognostic marker for which therapy, which one. So the alpha fetoprotein is scoring more in the, for example, in the liver transplant program, which is more than 400. Some of the centers more than 200. They will not offer the surgery. They will downstage the tumor, they go ahead. So, and the recurrence rate also they will see. Regarding the nuclear medicine scan, there is a FDG uptake. If the tumor is there, we can say it might be the poorly differentiated type of hepatocellular carcinoma. But that sensitivity rate is not that high. That is the drawback in the PET scan. Histological, we all know, once the tumor is, it's not applicable for the palliative therapy groups. Suppose if the resection or the transplant setting, that time we can come to know the recurrence after the therapeutic, whatever the modality, based on the histological type, poorly differentiated or moderately differentiated or well differentiated. Poorly differentiated group always will have the more of the recurrence. And again, the intracellular fat accumulation and the microvascular invasion, then the invasive growth in the bile duct or the vascular structure. This already I mentioned the scoring system in BAL. So here all the three biochemical parameter with bilirubin and albumin, the scoring system. But the BAL2 I mentioned here, there is the logarithmic score that shows the multivariate study, variate study is much better than the scoring system. There are the new, the parameters or the prognostic parameters are available. So there will be circulating markers. My earlier speakers spoke about more about the liquid biopsy, then the genetic markers, and the immunological markers and inflammatory markers. So the proteins in the circulating marker, but it's still under evaluation. So we no need to much concentrate on this. So liquid biopsy, earlier speaker mentioned. So more and more the liquid biopsy data are coming. The quantifying the circulating tumor cells or the circulating the tumor's DNA cells, we can assess the outcome, the recurrence. So it is not useful for the routine palliative therapy while going for the systemic therapy. It will be useful going for the either liver transplant or the in HCC in the non-cirrhotic group resection time to prognosticate and tell to the family member what are the chance of the recurrence. Either single gene or group of genes. There are so many genes. This also still under evaluation. It will take a decade to come to our practical applications. The new and interesting is the inflammatory markers. If you see here, we are not concentrated so far for the inflammatory markers, but more and more papers are coming up. These are easily doable in the HCC in the background of cirrhosis or non-cirrhotic. So there is the PNI means prognostics, the neutrophil index. We need just patient's albumin value and there the lymphocyte count. There is a formula I have mentioned. Similarly, if you go to the blood cell ratio, neutrophil lymphocyte ratio, platelet lymphocyte ratio, APRI score we know, and the AST, ALT ratio, and ALT and lymphocyte ratio, AST and neutrophil ratio, and the systemic inflammatory index, then macrocyte lymphocyte ratio. So just looking into the CBC parameter, so we can use the blood cell ratio. There are the evidence, so many the papers has come up. We can use this also to prognosticate the HCC recurrence. So AFP is a low sensitivity, low specificity, and it is less useful in MAFLD induced HCC as a marker. If you take a PIVCA2, the out is better in the HBV related HCC. ALB score, it is just albumin and bilirubin score. This ALB score is useful for long term to prognosticate in a cirrhotic individual. It's better than MELD score. MELD score for short term mortality. ALB will be the long term mortality better score. And this score is also applicable in the background HCC in the background of the cirrhotic case. And microvascular invasion, strong predictor, but we will come to know after the resection and the explant liver only. Circulating tumor DNA, useful to predict whenever the patient going for the surgical option. For liver transplant, to assess the outcome, we shouldn't use the much alpha fetoprotein is okay, but the retreat, which includes the alpha fetoprotein, microvascular invasion, and the explant liver wise the response of the tumor, the earlier downstaging wise the necrosis. So retreat score will be a best useful score to predict those who are going for a liver transplant. For TACE response, there are so many scores are there. And the BALD2 scores, and it's not widely used, but it's a better. So ladies and gentlemen, there are the several scoring system to prognosticate HCC there, but we have to choose if the patient going for liver transplant. From the explant liver retreat score. If the patient go for TACE, there are so many scores. If the patient's going for the systemic chemotherapy, so that time you have to look in, I am not showed here, PD-1 receptor expression. So we have to choose that kind of the scoring system and the BALD score for the combination of all the biochemical score prognostic marker with the background of the liver, so albumin and bilirubin. Then it will show the we can say the better prediction, and we can easily explain to the family member also. Thank you so much for the kind attention.
Thank you, sir.
Professor Varghese, excellent talk, sir. Recently, as part of one of our students' DNB program, we tried to see the correlation of PDL1 along with alpha fetoprotein and PIVKA2 as a prognostic marker. It turns out to be negative. Any thought on PDL1 as a prognostic marker, sir?
Yeah, so the PD1 expression in the HCC is useful to whether we can start the A to B, the chemotherapy or not, the immunotherapy or not. It is not useful as the prognostic marker to predict, because how the non-AFP secreting HCC tumors are there. Similarly, PD1 without expression, the HCC is also there. So it will be the useful only for whether we can use the atezolizumab with bevacizumab or not.
Thank you, sir. And for the last talk of this session, I would like to request Dr. Sunil Taneja to please come onto the stage.
Good afternoon, and thank you, Professor Arora, Dr. Ashish, and Dr. Praveen for inviting me here. So my job is to discuss the role of SBRT in HCC and in the current 2025. Now, I'm not going to discuss the mechanistic aspect of SBRT, how it is done, but I'll just take you through the journey, how and where is the role of SBRT in the management of HCC. So there's been a paradigm shift in the management of HCC, and from no treatment to surgical treatment, loco-regional therapy, systemic therapy, and the new kid on the block is SBRT. Each modality has inherent limitations, and you have to look at the technical feasibility, safety, and efficacy before you decide on the treatment. Now, the first report of using SBRT in HCC was reported way back in 1995. And this was a Swedish study where they reported 42 patients in which SBRT was used. But then if you look at the BCLC algorithm for management of HCC, it has not been mentioned. So why this has been not mentioned in the management protocol, I will discuss in my subsequent slides. But then let's look at the Indian guidelines. The Indian guidelines do recommend use of SBRT in patients with HCC. And this is especially in advanced HCC. The C1 category where you have the vascular invasion, and in the B2 category where you have well-defined nodules and preserved flow and selective access where SBRT or TACE and TARE can be used depending on the situation. Now, studies are there and well established in advanced HCC, but some data of the use in the B2 category also. So, how does SBRT work? It depends on the total number of fractions and radiation dose per fraction that external beam radiation therapy will work, and it can be divided into 3 groups. One is the conventional therapy, in which the dose is 1.8 to 2 grays per fraction and treatment is delivered over weeks. The second is the hypofractionated, in which the dose is more than 2 grays to 5 grays and it takes around 6 to 15 fractions, and I'll be discussing SBRT today, in which highly conformal ablative radiation dose measuring more than 5 grays. It's usually around 30 to 40 grays per fraction and given in 1 to 5 fractions over a period of 1 to 2 weeks. Now, what are the advantages of SBRT? It's a non-invasive treatment, can be delivered safely to patients unsuitable for other invasive medical procedures, and it can be given in all stages of BCLC. It has the ability to target the tumor precisely with a steep dose gradient, that is limiting the dose to the non-involved liver and surrounding normal structures. Now, what are the broad indications and prerequisites for SBRT? Indications are in patients who are unsuitable or refuse for surgery or ablation, in single or multinodular tumors including PVT that the radiation field can encompass. Now, what are the prerequisites? Good performance status, child A to B, ALB grade 1 and 2, a good liver volume, and appropriate organ function, which includes a WBC count more than 3000, a good platelet count, a hemoglobin of more than 8, and total bilirubin less than 3 milligrams. So, how has the role evolved for SBRT? Now, you can use SBRT as a bridge to transplant in all stages of BCLC, A, B, and C, in patients with portal vein thrombosis. It can be used in an alternate treatment to TACE or RFA, or in recurrent tumors as a salvage therapy, and I will show you the data for this. It has been used as a sequential therapy for TACE and as a bridging procedure or a downstaging technique to obtain the possibility of surgery as well. And there is some data on the use of SBRT for oligometastasis, especially to lungs and the bone. Now, just let's look at the data for this. I'm not going into the details of all studies. Let me show you this meta-analysis, a recent meta-analysis. Better local control with SBRT at 1, 2, and 3 years, and significant better 1, 2 overall survivor as with RFA as compared to SBRT. So, RFA still fares better in overall survival as compared to SBRT. But then if you look at the other studies, there is a mixed response. Some say that survival is improved, some say only the local control is improved. But then the caveat here is we do not have a head-to-head randomized controlled trial to support that SBRT can still be the first-line treatment for small HCCs. Now let's look at TACE. A recent meta-analysis, 1 year local control was better with SBRT, 88 versus 71%, and SBRT and TACE had similar 1 year survival rates. So again, the broad indication is where you can't use TACE or RFA, SBRT should be used. Now, when we combine TACE with SBRT, the results are better with SBRT. In comparison to alone TACE, TACE plus SBRT has a better overall survival as compared to TACE alone or SBRT alone. So, combination therapy works better. Now, can we use SBRT for bridging and downstaging of HCC before transplant? Again, a very interesting paper just published recently. 88 patients, 58 received SBRT as bridging and 30 patients received SBRT as downstaging. The probability of getting survival liver transplant at 6 months was 30% and at 12 months was 61%. Look at the post-transplant outcomes. With bridging, 5-year survival was 83% and with downstaging it was 73%, which is pretty good. Now let's look at the role of SBRT in advanced HCC and portal vein thrombosis. Multiple studies have shown good local response and improvement in local as well as systemic response to treatment along with the other therapies. Now let's look at this recent data, 2024. Recanalization of portal vein achieved in 60%. That means they can be eligible for transplant. And mean overall survival 18 months versus 9 months. So definitely works well in patients with portal vein thrombosis. Let's go further in advanced HCC with IVC tumor thrombosis. Again, response rate pretty good. Look at this, 75% complete response and stable disease in 25%. And recent data shows survival is comparable to systemic therapy, around 9.5 months. Again, a useful tool to be used in patients with IVC thrombosis. Now, let's look at large HCCs and in patients who are elderly. This data is from ILBS. Obviously, it's difficult to manage patients who are elderly. In this study, there were patients, the mean age was 75 years. 24 patients were included, predominantly males. And look at the survival. 14 months overall survival and progression-free survival of 9 months with large tumors in elderly. Obviously, it's an important study. And where you cannot use systemic therapy or you can combine it with the systemic therapy, this appears to be a very good option. Now, let's look at the metastasis. Now, we know that HCC can metastasize to lungs, lymph nodes, and bones. Again, a recent paper in JH. Look at the overall survival, 88% at 1 year, and at 2 years it is 80%. Though the progression-free survival was around 20% only. But then obviously, especially in bone metastasis, this is very helpful. Now, palliation is very important component of management of any tumor. Patients who are unfit because of extensive disease, this study looked at control of local symptoms. Pain is definitely an important symptom in patients who have metastasis to bone. Now, in this study, they had 65% patients who had pain and abdominal discomfort in around 34%. At 1 month, there was improvement in symptoms in around 51%, and median time to symptom progression was around 89 days. So again, as a palliative modality, this SBRT looks pretty impressive. It's not safe always. Obviously, you can have side effects. Radiation-induced liver injury is a major side effect. Now, classical radiation-induced liver injury doesn't really happen with SBRT. Incidence is less than 5%. You can have hepatitis, worsening of ascites, and elevated liver enzymes. And this is pathologically characterized by veno-occlusive disease. The non-classical radiation-induced liver injury typically occurs in patients who have underlying cirrhosis, which most of the patients have. This is seen in around 20 to 40%, and it manifests as elevated enzymes and worsening of CTP scores. But then overall, the tolerance to SBRT is much better. It can also cause damage to the vascular structures and sometimes to the GIT if there are exophytic lesions which are being targeted. But then the most important part is cost effectiveness of any therapy. We know that TARE is very expensive, immunotherapy is very expensive. Now let's look at the cost effectiveness of SBRT. It's pretty cost effective. It's an OPD procedure. No need for hospitalization during treatment, and there is a comparison from US. Look at this comparison, 62,000 versus 1,27,000 for 2 sessions of TACE. And we know that TARE is even more costly. So in India, obviously the cost of SBRT is much less as compared to the other procedures. So let me summarize. SBRT has emerged as a promising treatment modality for managing HCC, evolving from palliation in late stage disease to a role in early stage HCC. It is now recognized as an accepted LRT for curative intent, downstaging or bridging to transplantation, as well as palliative care. It has demonstrated comparable or superior efficacy in tumor control compared to conventional local regional therapies, although we do not have head-to-head trials, we do not have randomized controlled trials. And combination or sequential use of local regional treatments can yield favorable outcomes in appropriate setting. SBRT has also shown promise in combination with immunotherapies. There is some data to suggest that. However, caution is warranted in patients with poor liver functions, and you have to optimize patient selection before you take decision to treat patients with SBRT. Thank you very much. I will stop here and I'll be happy to take questions.
Dr. Sunil, what is your comment on this exciting new data which is coming up on combo therapy, wherein SBRT is combined with immunotherapy?
Yes. Yes, there's some trials which have been done recently, and they say that if you do give immunotherapy and combine it with SBRT, the results are much better.
Because it makes a tumor more naked and make it more effective.
So immunogenicity is improved and the response to immunotherapy is much better also.
So do you have any data on how is the efficacy of that?
So I don't remember it offhand, but it's published now.
So I think any sort of radiation, whether it is TARE or SBRT, the same effect comes. So there is a data of that is upcoming, and some small studies have shown that even the TARE causes the same effect of increasing the immunity. So comparison of TACE versus TARE is more beneficial in causing this effect.
So that is the abscopal effect.
Abscopal
Yeah.
effect. I think
Sunil, I think they were good questions and a good presentation. I have a couple of top points on SBRT. One is the problem of respiratory gating. Now, CyberKnife technology is available in many centers in India, which takes care of respiratory gating. Does it improve results? Any data with the use of CyberKnife in HCC? That's one. The other thing is that you talked about in PVTT the use of SBRT. Does it actually completely clear the tumor or just converts PVTT into a bland thrombus? And finally, how good is the tumor kill? When you're radiating with such intensive radiation, particularly with a CyberKnife, do you get a 100% tumor kill, or there is still viable tissue left in the lesion?
Sir, I think I will not be able to tell you the mechanistic aspect of SBRT, but then recanalization, I've shown you that in one study they showed recanalization to the tune of 60%. So definitely there is a resolution of PVTT.
I don't agree with the data you have shown, that in practical everybody has the experience of SBRT, and I haven't seen any of the patient getting the complete recanalization. And even the Medanta study of Dr. Soin also, in the PVT patients, the main role of the SBRT to complete control the tumor at the PVT site. They doesn't get recanalized. Don't think that even the TARE or SBRT are going to recanalize the complete portal.
So can I briefly answer this? SBRT can totally clear the PVT. We have data and we have done post-transplant after that. In fact, many patients, we just do SBRT for PVT and in the tumor area. So I think, and this has been published also, maybe this year or so. That's part one. Part two, about the question that you asked, whether SBRT is to be done. SBRT followed by ICI is good, but single dose, this is called pulse SBRT. So you do one SBRT and followed by that, you can give ICI, but the risk is high. We actually had one patient with very huge flare. And third, the gating part, all the machines now come with respiratory gating. And I think there is just no problem in gating. It is very, very focused. And it's actually very economical, and we all feel SBRT is a good modality.
Dr. Arun, we had one patient who had portal vein thrombosis, and that patient had recanalization, and he was transplanted after that, and he did very well after that. So there is data on that. Recanalization data is there.
So my question is to you, sir, Dr. Sarin. One of your slides showed that sorafenib decreases the portal pressure but increases the bleed. But we all know that it's directly correlated to the portal pressure and the HBPG. How is this paradox? I asked you, I could have asked you because just for the general public.
Actually, sorafenib is anti-angiogenic in a way. So there is animal data, you're very right. There is no human data that it increases the bleed, but this is only the animal data. So in humans, I think sorafenib is generally safe even with large varices. But I would always give beta blockers, whichever way, and bring down before I do anything else. Yeah, so there's only one gut study, but now there are many studies which are ongoing. I think both is better. Everyone should have beta blocker plus EVL or no, that is the question. But beta blocker is a must.
We have been told by organizers we are running late. Professor Sarswat wants to say something.
Just one quick one, sir. Maybe, sir, you would have the idea, Dr. Sarin, that once you explant the tumor after SBRT, explant the liver, do you get viable tumor left in the SBR radiated area or not?
After SBRT, very few would get the transplant because they are generally large tumors of, so post TACE we have, there is a total necrosis, but post SBRT I don't recollect whether there is an explant liver as total necrosis.
I mean, many of the things are to be answered by radiation oncologists. Unfortunately, we don't have Gagan here. The cost of an SBRT is about 4 lakh compared to TARE is about 12 lakh. So it is definitely cost effective. TARE plus SBRT has been, and in Apollo, people are doing it. Maybe some or not always recanalization, sir, but the main idea is to converting the tumor thrombus into a bland thrombus. And post that, people are doing transplant, but the risk of recurrence will remain high with the tumor biology. So with that great talk, Sunil.
Thank you. Thank you, sir. For our next session,
For our next session on futuristic insights on HCC, we would like to invite on stage our moderators, Dr. Manjeet Paul, Dr. Amar Mukund, Dr. Saurabh Srivastav, Dr. G.N. Yatu, Dr. Ramila Shrestha, and chairpersons Dr. Rajan Saxena, Dr. Arun Gnavli, Dr. Shailendra Kishore, and Dr. Akshay Bhangale. The first talk on should we replace TACE with TARE in management of HCC, we would like to invite on stage Dr. Yogesh Chawla.
Thank you, Anil, Ashish, and Praveen for asking me to talk on TARE, something of which I'm not a specialist, but while going through the literature, it was quite interesting. We know that the management of HCC is dependent on the tumor burden, underlying liver function, and the functional status of the individual. And BCLC staging, it tells us about the prognostication and treatment strategy. The recent INASL guidelines in 2023 have said that BCLC-B is a heterogeneous group and we treat this for curative intent or supportive therapy. And you have B1, B2, B3. B1 is ideal for liver transplantation when the nodule is more than the transplant criteria for which you require downstaging. B2 is beyond B1, but you have multiple nodules for which TACE and TARE is recommended, and diffuse infiltration and extensive bilobar involvement for which systemic therapy is done. Similarly, BCLC-C is a heterogeneous group with C1 involving the vascular invasion, for which TARE, SBRT, and systemic therapies are advocated, and for C2, which is extrahepatic spread, supportive therapy is important. So, we've been talking about transarterial therapy and locoregional therapies. Just briefly taking you through the TACE. Liver is mainly supplied without HCC with portal vein flow, and only 25% is hepatic arterial flow. Whereas in HCC, it becomes converted into a hepatic arterial flow for which you need to do an obstruction and lead to tumor necrosis. TACE has always been indicated for BCLC-B, and this group mainly is when the tumor is less than 3 centimeters without vascular invasion, and studies have shown that it decreases the tumor burden, controls the tumor growth, and improves the survival. And it is a good modality for bridging for transplant where the wait list is more than 6 months. But with TACE, there is incomplete response, and this is due to hypoxia, which is induced by the therapy, and that stimulates VEGF, which is responsible for some of the viable tissue. And TACE is contraindicated when the bilirubin is more than 3, there is complete portal vein thrombosis, liver failure, and extrahepatic disease. Briefly, there is conventional TACE, which we usually do. You have drug-eluting beads, DEB TACE, and meta-analysis has shown that there is no difference in tumor response and survival rates between the two. You have balloon TACE, where you introduce a balloon while injecting the chemotherapeutic agent and lipidol, but this has been associated with higher vascular damage. You have DSM TACE, which is something which has come up, also known as degradable starch microspheres, which tends to have lower liver toxicity and a temporary embolic effect. So, there are enough studies to say that TACE is effective. It improves the overall survival 60 to more than 20 months when compared to supportive care. It is best in early stage HCC, and response rates vary with tumor stage and patient factors. And you call it refractory after the patient has not responded after 2 to 3 treatments. And there have been studies where combination of two locoregional therapies or systemic therapies have been tried radiofrequency ablation with TACE, microwave ablation with TACE, and sorafenib with TACE, all of which have shown improvement in survival. Now, coming to TARE, this is ideally yttrium 90 microspheres, mainly in the form of glass, but you have resin microspheres also, which has been used mostly in colorectal metastasis. Recently, I-131 iodized oil has also been used, and it traditionally has been used for locally advanced HCC, and regression has been shown to be to the tune of 25 to 50%. In fact, it is now considered as a loco-regional therapy like ablations. So, what happens? Microspheres tend to lodge in the arterioles with minimum embolization. So, there is increased high energy beta radiation with a low penetration of 2.5 millimeters and not 2.5 centimeters. It's extremely safe, effective. It gives longer time to progression, greater ability to bridge while waiting for liver transplant. And a comparison between TARE and TACE earlier on has shown that there is no difference in the overall survivals. Probably TARE is a little better for larger tumors, and these studies have gone up to 8 centimeters of HCC. The objective response rate and disease control rate are almost same, but where TARE becomes an advantage is the safety profile. 72% have side effects with TACE, whereas only 5% have side effects with TARE, and that is where TARE scores over TACE. So, when TARE was tried in about 1,000 patients over a period of 15 years, the overall survival improved with BCLC A, B, and C. TARE has been compared with DEB-TACE. It has been shown to be better. TARE with sorafenib has been shown to be better. And TARE in HCC with portal vein tumor thrombosis has been found to be more effective in downstaging to surgery and improved overall survival. A very recent study came out with a meta analysis where TARE was compared with TACE for inoperable HCC. And of the 8 studies, large number of patients, TARE had a higher pooled total response, disease control, and 1 year overall survival. But there was no significant difference in complete response, fatigue, nausea, vomiting, 3 years overall survival, and 5 year overall survival. And all indicated that high radiation doses to tumor capillary bed induced more tumor necrosis than TACE. So the complications were very few, and they concluded that higher treatment response, survival, and better quality of life is there with TARE as compared to TACE. So, TARE, because of the beneficial effects, it has been included in the BCLC 2022 staging system. When you give TARE, you tend to produce radiation segmentectomy if there is a single nodule in one of the lobes, and that is known as radiation segmentectomy. And radiation lobectomy is when there are more number of tumors in a single lobe, and all of them die because of the TARE procedure. There is a concept of personalized dosimetry, which has been shown that higher the dose that you give to these patients, more are the chances of response and survival. Another advantage that has been reported is substantial hypertrophy of the contralateral lobe, broadening the eligibility of definite surgical intervention in about 40% of cases. So, TARE, from being used in intermediate or unresectable HCC, has also been tried in early HCC with very good results, giving an advantage over radiofrequency ablation, microwave ablation, when the tumor size is between 5 and 8 centimeters. Same is true for intermediate stages, BCLC B, HCC, where again TARE has scored over TACE. There has been a study where TACE was followed by TARE that again had shown positive results with the combination, but you cannot justify till you have wider applicability. Almost 35 to 50% of HCC patients have portal vein tumor thrombosis, and according to the Japanese classification, this thrombosis is VP0 to VP4. VP4 is main involvement of the portal vein, and VP1, 2, 3, the segmental branches of the portal vein. So, it has been found that the prognosis in patients with higher the portal vein thrombosis from 1 to 4, the mortality is more. So by and large in this group, TARE has been tried, has shown some positive results, and tailored dosimetry has always been better than the standard dosimetry. And studies have shown that it is as good as atezolizumab and bevacizumab, and possibly there is a role for combination with immunotherapy. So trials comparing with TARE offers superior tumor control, longer time to recurrence, greater overall survival in BCLC A and B, and it has a major role in bridge to transplant or downstaging. And side effects, as I said, they are much less. Radiation-induced liver disease is seen very rarely. You may have gallbladder ulceration or GI ulceration if you do not target the embolization properly. The selection criteria is the same as that for what you do for TACE, except it is contraindicated when there is a arteriovenous shunting in the tumor, there is pulmonary shunting more than 20%, and patients with severe renal and liver dysfunction. There have been some advances in TARE. Imageable microspheres have been introduced, pressure enabled delivery systems so that the heterogeneity of the delivery to the tumor is avoided. Holmium HO166, which is a paramagnetic imaging MRI, has also been tried. And of course, combination therapies, like any other difficult to treat cases, has also been tried in HCC. This is just a comparison between the two. You can keep on repeating TACE every 6 to 8 weeks, but you tend to call it refractory if the patient does not respond in 1 to 2 treatments. The biggest problem with the TARE is the availability is not widely available. It's very, very expensive, but it is generally better tolerated and best indicated in patients who have portal vein thrombosis or patients who are not able to tolerate TACE. So, friends, in conclusion, I would say that TARE is indicated in the Indian context in unresectable HCCs, which are large, or if there are multiple lesions, provided the liver functions, patient belongs to Child-Pugh score A or early B. Response is marginally better than TACE. Advantage, it is indicated in portal vein tumor thrombosis, has minimal side effects as compared to TACE. The only disadvantage, and a very big disadvantage, is that it is very expensive, limited availability. So, in conclusion, I would say that TACE can be replaced by TARE in limited situations where affordability is not a major problem. And I would personally give it to patients who have large HCC and portal vein tumor thrombosis if all other modalities do not fit into the criteria for this patient. So, thank you all for your patient listening.
Thank you, sir. For the next talk on efficacy of immunotherapy in HCC in real world versus clinical trials, we would like to invite Dr. Anand Kulkarni.
Thank you, Anil sir, Ashish sir, and Praveen sir for inviting me here. I know, I heard the talk on TACE and TARE. It's very interesting. I'll be talking on one more expensive therapy, that is immunotherapy in real world versus clinical trials. Briefly, I'll be more sharing about our experience and candidates, how we select for immunotherapy. What actually is immunotherapy is these are physiologic breaks which are expressed in all cells. So cancer cells, dysregulate them. This is what we target. These PD-L1 inhibitors, PD-1 inhibitors, and CTLA4. The drugs target this, prevent the dysregulation, then unleash the immune system on this liver cancer. These are the two individuals who got the Nobel Prize in 2018, James P. Allison for identified the CTLA4, and Tasuku Honju in Japan, who found out the PD-1. They were jointly awarded the Nobel Prize, and they have been the backbone for all the immunotherapies which have come in for all types of cancer in recent years. Now, immunotherapy is the standard of care for HCC, and it's the recommended first-line therapy. The available ones in India are atezolizumab and bevacizumab, the combination of single dose of tremelimumab and multiple dose of durvalumab. Toripalimab and bevacizumab also has a good efficacy. Nivolumab and ipilimumab is also available and has been used in fewer situations. We have more experience with atezobev, followed by a little bit of stride, and one patient with tori-beva who actually have a good response. To compare this study, our title which have been provided is Clinical Trial versus Real World Evidence. Basically, RCT is where we have intervention, there is experimental. It is protocol based, there are a lot of exclusion criteria and lesser of inclusion criteria. There is a comparison which is gold standard like placebo or sorafenib for HCCs. There is randomization, there is blinding for these trials. On the other hand, real world evidence is basically non-interventional, it is more like observational. There will be no comparator arm, but that is our real world situations which we actually face in India, and it has more clinical relevance. So there is a magic of randomization, but myth of real world evidence is there as well, which we have to know. Multiple lessons from our real world evidence, which I will just share in the next few minutes. Inclusion criteria of all the major trials on immunotherapy have this: no prior systemic therapy, BCLC B or C, child pug A. The problem with us in India is presentation of patients with HCC at child pug A status is very, very rare, and good performance status. Most of our patients, when they come to us, are symptomatic, they are advanced, either in child B or in child C. This is the study from PGI, around 700 plus patients, where they have noted that almost 38% present at child B and 10% at child C, hardly around 40% at child A. This was a retrospective analysis, and most of them are in BCLC C or D. There are multiple tumors in 56% of the patients. This is also similar in USA, it's not just India. When they face the same challenge, that most of their patients also present at advanced stage. They are either in BCLC C or D with advanced child pug stages. One more study from CMC Vellore, that most of these patients have decompensation, that is ascites in 57%, jaundice around 22%, and only 22% are diagnosed in surveillance. So we lack a lot of strategies required to improve the surveillance for HCC to identify them early. Probably the role of biomarkers like GAD and GALAD can be used in routine practice to improve the early identification and probably provide improved outcomes for this patient for early identification of cancers. This comes to our problems in the real world, that is late presentation. They are usually symptomatic with ascites, jaundice. Less than 30% are actually candidates for ideal systemic therapy. And who is the ideal candidate for ICI versus TKI? We still don't know. There have been studies which have been conducted on biomarkers, but none have been actually been used in clinical practice. Multiple real world evidence from India, there is one from ILBS, one from Tata Memorial Hospitals. Everybody has their own presentation. All these are retrospective data, and we have reported that these patients, even if they are not fitting the criteria of clinical trials, their outcomes are equally good to those compared to those who are in clinical trials. I'll just share our experience. This is our study which was published in JCEH. We had around 67 patients, some from our institute and some from Mahatma Gandhi Institute from Professor Saraswat's team. The etiology of liver disease here was NASH. It is around 55% of patients were NASH. Child pug A was 35%, child pug B around 53%. In the initial stages, we were not aware of the identification of these patients. There are some patients in child C also. There is BCLC C where 75%, A where BCLC B were 9%, and BCLC D in 11%. Very few patients had received immunotherapy, prior systemic therapies or local therapies prior to this. This is the IMBRAVE study where they have reported that on RECIST criteria, 5 to 10% achieve complete response with atezolizumab, bevacizumab compared to 0 in sorafenib, and 21% had partial response compared to 11% in sorafenib group.
So the overall response rate was around 27% versus 12%, and disease control rate was around 73% versus 55%. This is our response rate. Complete response around 13%, partial response 26%, ORR around 38%, and disease control rate 66%. We have gradually improved this. We have a large number of patients now, and we are very selective in using this drug in recent times, and we see good response. We have been able to transplant them even if they are outside of clinical trial criteria. Now coming to STRIDE, this is the clinical trial which was published in NEGM Evidence, and the recent updated analysis which has been published in JHEP, showing 5-year survival rate of almost 20 to 25%, excellent efficacy in clinical trials. But somehow we have not been able to use this. There are a lot of side effects which occur with the combination of two immune checkpoint inhibitors. But this trial did not report any risk of bleeding, variceal bleeding. That is the reason the current guidelines suggest using VEGF inhibitors only in patients who do not have risk of variceal bleeding. If an individual have high risk of bleeding, or a patient who has high protein creatinine ratio, he is a candidate for STRIDE, that is Durva and Tremi combination. If an individual has autoimmune disease, then probably should not give any of these immune checkpoint inhibitors. They should be directly taking lenvatinib or sorafenib. If a patient has only child pug B with poor performance status, elderly, Durva or nivolumab alone can be tried. But if we see here bleeding risk, yes, we agree that STRIDE should be given, is a drug of choice. But this is our experience. We have lost 2 patients because of STRIDE in recent times. Both of them had actually had high risk of variceal bleeding. They underwent SBRT, followed by they received this STRIDE combination after around 6 weeks. This is a 53-year-old male who had MAFLD. He had received SBRT followed by STRIDE. He had past history of variceal bleeding. That's the reason we ordered atezolizumab combination. We also documented response with post SBRT. There was resolution of the portal vein thrombosis, but then the patient again had a massive bleeding, and we lost the patient just because of bleeding. We also had similar patient recently who was treated with STRIDE somewhere else, and we lost the patient because of bleeding. So in real world evidence is completely different from what you see in clinical trials. One thing, but STRIDE, the Himalaya trial awarded patient with portal vein thrombosis. Here we had included patients who had portal vein thrombosis. The second patient did not have, but the first patient had portal vein thrombosis. In the real world, we are able to transplant these patients post immunotherapy. This is our experience, which has been published. There are around 12 after 5 patients who had been downstaged and were planned for transplant. Hardly around 6 we could transplant them. 4 had undergone LDLT, 1 DDLT, and 1 patient who had undergone resection. One important caveat, what we note in patients who have received atezolizumab, their wound healing is very delayed because of the bevacizumab, and we have had wound sepsis post-surgery when they receive this atezolizumab in pre-transplant settings. The median time was around 80 days from time to transplant was around 80 days, and we had good results with this. All the patients are following up, except one patient who underwent DDLT has developed a recurrence after around 2.5 years recently. So for ideal candidate for systemic therapy, especially for immunotherapy, what I mean here is ECOG performance less than 2, BCLC B or C, child pug A, up to 8 only if the bilirubin is less than 3. If there is mild ascites, we would be okay. We would not take patients with bilirubin more than 3 or a patient who has hepatic encephalopathy. Age, etiology, and tumor burden. There are multiple studies, contradictory studies. We think it is unrelated. There is no role of those age, etiology, and tumor burden. ICS, it is must to rule out autoimmune diseases. For atezolizumab, evaluate for varices. All the patients should undergo evaluation for varices. Beta blocker and statins we use frequently for these patients to reduce the portal pressure. Simvastatin at 10 to 20 mg per day. For patients who have higher alpha fetoprotein, we would prefer a second line drug of ramucirumab if the patient progresses on atezolizumab. To summarize, you have to choose your patients. Everybody has their own way of treating the patient. SBRT followed by immunotherapy, TARE followed by immunotherapy, or immunotherapy followed by SBRT. When I discuss with my colleagues in US, they are now shifting from SBRT followed by immunotherapy versus they are now changing from immunotherapy followed by SBRT. The reason being there is some risk of liver failure which they note in their population. Although not everyone will benefit from ICA therapy, that doesn't justify that we should deny this in real world evidence, based on the real world evidence. Probably yes, we need to have them look them at their bilirubin. It should be less than 3 and it should have good performance status. And efficacy of IO is similar in real world compared to those in clinical trials. I would like this opportunity to invite you all for our liver conclave, which is being held on 26th and 27th of September. Thank you.
Thank you, sir. For the next session on liver transplant in patients with HCC beyond transplant criteria, we would like to invite on stage Dr. A.S. Soin.
After this session, we will be breaking for lunch, and during lunch, we will have two symposiums in this hall, one on Linaclotide and other on Nor-UDCA. So those who will be interested can stay back.
Thank you very much. The CHBD team, Dr. Anil Arora and his team for inviting me for this talk. So I'm going to talk about liver transplantation for HCC beyond conventional criteria for transplantation. Is it a hope or hype? You obviously know the answer already, but I'll try and show you why. So we all know about Milan and UCSF criteria. I recall them here just to tell you that they are basically buried now. Simple morphological criteria do not cut it in liver transplantation for HCC anymore. So although these conventional criteria are still some kind of baseline and foundation on which the tumor biology based criteria are built, but they alone on morphology are not the guidelines anymore. So size and number and utility, that means survival after transplantation, have actually given way to the new dogmas in liver transplantation for HCC, the size, number, and tumor biology. And instead of survival after liver transplantation, you see the transplant benefit, which means the incremental benefit of transplantation over non-transplant options for any given patient. So practically, I mean, our own criteria, but also INASL, also most of the liver societies and transplant societies of the world have actually adopted tumor biology-based criteria. The focus of today's conversation is on locally advanced liver cancer and what we can do in terms of transplant options for them. So let's first look at multifocal HCC. The top two pictures are a dream. We don't really see very many patients of early cancer. So multifocal HCC, there are two options. You can actually downstage them to within acceptable criteria and transplant them, or use extended criteria beyond UCSF and upfront transplant them. So in terms of downstaging, obviously these patients have to have no extrahepatic cancer spread or any macrovascular invasion. So Francis Yao from UCSF originally again published this concept in downstaging, where he said that de novo Milan or T2 prior to transplant versus those that were downstage to within UCSF prior to transplant did equally well in terms of disease-free and recurrence-free survival at 77 and 90% versus 81 and 88%. Mazzafer et al. 5 years ago published this phase 2b3 randomized control trial, where they pitched 45 patients with HCC with more than 50% possibility of 5-year survival using size, number, and AFP. And when they downstage people to within these criteria and transplanted them and compared them with those that did not undergo transplant with the exact same numbers and morphology, they found that 5-year survival of the transplanted group was 76% compared with 18% with no transplant. So the answer is pretty clear. UNOS have now gone on to including downstage patients in their criteria as well. So the entry criteria are single tumor 5 to 8 centimeters or total tumor diameter of up to 8 centimeters with no extrahepatic or macrovascular spread, and approximately 50% of these are able to be successfully downstage. A third of them have a transplant, and in a meta-analysis of 25 studies with about 4,000 patients downstaged, they actually had 1 and 5-year survival of 94 and 74%. So what about extended criteria with upfront transplant without downstaging? And that's something that we have innovated at our center. We were severely criticized for accepting patients of any size, any number for transplantation. We published this data about 4 years ago. But now more and more people believe that either upfront or with downstaging, these patients should not be denied transplantation. We've done about 5,000 transplants with about 1,000 HCC patients. But this series was until December 2017, which had about half the number, about 469 patients. And we looked at 405 patients, the right extreme box, where they did not have extrahepatic or microvascular spread. Milan 50-50 and UCS of about 60 within and 40 without. We had 5 and 10 year survivals of 64 and 55% overall with these criteria of all comers without any regards to size or number, provided they did not have extrahepatic spread or microvascular invasion. But we also then partitioned these patients into 3 types: low risk, moderate risk, and high risk patients based on AFP levels, based on whether they were within UCSF and based on whether they had FDG positivity, and then separated them into these 3 risk groups. And obviously, the high risk group with 2 or more factors did worse than the low and the moderate risk groups. And the other thing that we found was that the low and high risk groups had significant transplant benefit at 3 years and 5 years of 27 months and 42 months in the low risk group case, and 17 and 25 months in the high risk group patients. So basically, we showed that this selection of all comers did well for the patients for transplant, but there were some patients who were at high risk, which is how we then evolved our policy to downstage these patients. So low risk were given upfront transplant, moderate risk, if possible, were downstage to get them to low risk, and of course, high risk were definitely downstaged before they could have a transplant. Now, enough about what we did. What do the world guidelines say? So the first ILTS consensus guidelines, and I was the lead in this group of the world consensus, says that they recognize in 2020 that composite criteria considering surrogates of tumor biology and response to neoadjuvant treatments were likely to replace conventional morphological criteria. This was 5 years ago. And they said that the minimum acceptable recipient survival was in the range of 60% at 5 years. And then our own group, the Puri 3 recommendations of the INSL, we basically did a modified BCLC classification, separated out the A, B, C, D into 2 or 3 groups each. And the B intermediate stage was looking at more and more locally advanced cancer without extrahepatic spread or portal vein invasion. And basically, with some kind of neoadjuvant ablation, they were able to be taken to transplantation, or it was proposed that they can be taken to transplantation in a certain proportion of patients. So next, let's look at patients who have large HCCs or any size HCCs with portal vein tumor thrombus. This group has been, again, a group of controversial management decisions. And we were, again, the first ones in the world to actually do a priori clinical protocol to downstage these patients to take them to transplantation. This was an early report about 8 or 9 years ago by Sung-Yu Lee's group from Korea, where they showed that 17 patients with major vascular invasion who were downstaged with combination of TACE and radiotherapy, they were able to achieve a 3-year overall survival of around 60%. So this classification has already been shown to you by Professor Chawla, VP 1, 2, 3, and 4. So we published this again about 5 years ago, and so we have a protocol where we take patients without any extrahepatic spread, but with portal vein tumor invasion or portal vein tumor thrombosis. We've also taken patients with hepatic vein tumor thrombosis. And as long as they have good liver function, which is Child's A and B, and if they have at least 700 cc of non-tumor liver volume, then they are put through this protocol that they have preoperative evaluation like routine PET triphasic CT and everything, disease staging, If there are any nodes, they are subjected to EOS-FNA, and if they are negative, then we proceed. And then they have TARE and SBRT. And after TARE and SBRT, we wait 6 to 8 weeks. And then we do their PET triphasic CT again. And if the portal vein tumor thrombus has resolved, and that has two indicators. One is that the tumor in the portal vein loses its arterial enhancement, and the other is it loses its FTG ability. If that happens, then they are deemed to have responded, and the tumor in the portal vein is thought to be gone, and then they are subjected to or taken to living donor liver transplantation. The average wait period tends to be around 3 months. So this is what it looks pre, and this is what it looks post. There is loss of FTG avidity in the right portal vein tumor thrombus here. Even the main tumor, the FTG avidity seems to have gone. And we are able to, in this publication, we showed we were able to get an overall 5-year survival of around 60%, 57%. And updated results as of last year showed the same thing, overall and recurrence-free survivals of 60%. And we actually have currently 18 long-term survivors, 8 over 5 years, and the rest are over 3 years. All of these people would otherwise be written off and survive probably 6-7 months. Off late, there has been interest across the world in this protocol. So people have done it after downstaging PVTT, and they've done deceased donor transplants. And there is also interest in transplanting patients with PVTT with a combination of TARE, SBRT, and immunotherapy in various combinations. We've done 5 such patients, and they've had nivolumab in one case and atezobev in the other 4 cases. And all 4 survived after transplant. One we lost due to sickle cell disease 4 months later, and the rest are doing well out of these 5 patients. As has been feared, they don't really have bad acute rejection after liver transplantation as long as there is a washout period of at least 45 to 60 days. We published extensively on this protocol of downstaging PVTT and then transplanting them. And it's been now incorporated in the INSL PURI 3 guidelines. The C1 category can actually be taken through to transplant in selected cases after downstaging with TARE, provided there's no extrahepatic spread. It's also now come into the World ILTS consensus guidelines, which we recently did and published. And HCC patients with macrovascular invasion can be considered for liver transplantation after successful downstaging with a priori protocol. So that's what the latest ILTS consensus guideline says. So we are happy that it's been finally accepted by the world. So I'd just like to summarize here to say that these patients with locally advanced HCC without systemic spread will have good 5 to 10 year survival and significant transplant benefit from liver transplantation. The beyond UCSF HCC without vascular invasion and extrahepatic spread can be downstaged to within locally acceptable transplant criteria and give 60 to 85% 5-year survival, depending on inclusion criteria, depending on what your local criteria are, and whether you're doing LDLT or DDLT. The modalities of downstaging are TARE, TACE in some cases, usually TARE and SBRT, and immunotherapy. The second concept is about PVTT. All PVTT in HCC is not systemic spread. So selected patients of HCC with PVTT with good liver function and non-tumor liver volume can achieve nearly 60% 5-year survival overall with neoadjuvant downstaging with TARE, SBRT, immunotherapy, followed by transplantation. Thank you very much. I'm happy to take questions.
So if there are, okay.
Excellent talk, sir. I just want to know, for patients who are high risk, I mean, individuals who have got a large HCC or a, say, V1, V2 portal vein tumor thrombus pre-op, do you consider starting lenvatinib in the very early post-operative period, say 3 weeks or 4 weeks post-transplant, or would you reserve it for a recurrence and then?
So as you know, there is no clinically approved acceptable protocol of post-transplant TKIs for preventing recurrence. So we only use it when there is a recurrence.
Okay. All right.
Excellent talk, Dr. Soin. Is there any evidence that microvascular invasion, the liquid biopsies are positive, and then post-transplant they fare better or they fare equally well as compared to others?
So
Macro is okay.
yeah, sure. I mean, that wasn't really the focus of my talk, but microvascular invasion, patients who do have microvascular invasion are generally thought that they'll have a higher PIVKA2 because that's supposed to be a surrogate marker of microvascular invasion. So we do get pretty sensitive about transplanting patients with a very high PIVKA2, even if they don't have PVTT or otherwise locally advanced tumors. And we would tend to downstage patients if there's a PIVKA of more than 800. So that's one part, but we've not actually written it up. We follow the protocol.
And
but in some ways, I think microvascular invasion being present versus not is a poor prognostic sign.
Any role of high dose of vitamin K?
I know Dr. Sareen loves this, but we've not tried it.
Quickly, I think very nice talk, Dr. Soin. But before that, Anand, if you are around here, any experience with the new PD-1? We have this.
The Durva and Tremeli?
No. The newer one is still off-label. That's called the toripalimab, which is the TARE and Babeso, and there's a recent Lancet gastrohepatology paper. This is a study, phase 3 from China. The advantage with tori with Bevo in comparison to sorolanib, tori is much cheaper than not only the stride regimen, but also cheaper than the A plus B regimen. We have started using tori in some of our patients. I thought if somebody has experience. My question to you, which we have already discussed many number of times, is downstaging with immunotherapy. You showed some of your experience in 5-7 patients, but then downstaging with extrahepatic disease and then transplanting, is that an option now open or still closed?
It's on the cards. We haven't done any, but that's a clinical protocol that is written and ready in our institution.
Thank you, Dr. Soin. That was an excellent talk, and I thank all the other speakers in this session. And now we adjourn for lunch. Thank you.
Thanks.
So we will be having a lunch symposium during lunch break. And the first session is New Era in Constipation Management, introducing Linaclotide in India. This session will be moderated by Dr. Praveen Sharma, and the lead panelists are Dr. Afzal Anis, Dr. Ajay Gupta, Dr. Aliza Bhattarai, Dr. Alok Kumar Raha, Dr. Anurag Jha, Dr. Arvind Kumar, Dr. Bhupender K. Basnet, Dr. Hasmukh B. Vora, Dr. Mohan Bhusal, Dr. Mukesh Agarwal, Dr. Nishant Wadhwa, Dr. Nirajan Subedi, Dr. Nitin Goyal, Dr. Pawan Pandey, Dr. Rabin Koirala, Dr. Ravi Prakash Sharma, Dr. Ravinder Pal Singh, Dr. Rupesh Lunkad, Dr. Sanjay Podyal, Dr. Sunanda Sen, Dr. Surendra Nath Swain, Dr. U. Bhandari, and Dr. Yuvraj Bhusal.
Okay. So, good afternoon, everybody. So, I will be talking about this symposium is about the linaclotide, which has recently been launched by a company. So I understand that it is a lunch time. So anybody who is interested, they can have their lunch and they can come back over here. And if you wish to take their plate, and they can go and they can come with their plate inside. Is that okay? Yeah. So maybe yes, it's okay. Yes. So I think after listening to about 1.5 or 2 hours of MAFLD since morning, I think constipation is something like a MAFLD. We have number of newer drugs which are coming up, and most of the drugs are not working in MAFLD. So similarly, I think the constipation, which is a day-to-day clinical problem, We have lots of drugs which are now coming up, but I don't think any single drug fits into any particular patient. So every patient has to be individualized. So we have a good number of our expert people. I think first of all, I wish to maybe a single line from everybody, that what is their experience of treating a constipated patient in their clinical practice, because it's a very common problem. Patient come to us with a history of constipation for 30 years, 20 years, maybe they have taken all sort of drugs. Whenever you try to write down some drug, they said, oh, I have already taken this drug, please prescribe something else. Sometimes when you write 2 or 3 drugs, then say, I have already taken all those drugs, and what to do now? So this is a very, it's a real time challenge to treat a patient who has come to you with a constipation with 30 years or 40 years of constipation. So maybe we start from right from the beginning. If you wish to say anything in your clinical practice, how commonly you see constipated patient and what do you do in all these patients?
I am a surgeon, so I also get many patients of constipation. So I'll try to dig into more history, like what actually they mean to say by saying constipation. Like either it is a IBS or a real slow transit, or they have a hard stool. So I try to figure out and then try to investigate more what they mean. It may be a ODS, or it may be a slow transit, or maybe hypothyroidism. So and then accordingly I go along.
I think I got your point. I think taking a history is very important. In our, if you go by the books, constipation means if you pass less than 3 times stool in a week, it's a constipation. But most of our patients, they said they pass about 8 to 10 times stool and still they are constipation. So it means, I think it is you need to understand what the patient is saying, whether he has a feeling of incomplete evacuation. Sometimes he said, like he says, defecatory problem, whether he's trying to use his finger to take out the stool. So if you particularly listen to the problem, then you can understand that what does the constipation mean. So constipation, if we go by the books, I think that will not matter much to our patient. We need to understand the patient perspective. As we go by the second person, what he thinks that.
I agree with you, Dr. Praveen. As a surgeon myself, I would agree with what Dr. Saab has said, that constipation per se, as per what the Milan criteria or the other criteria, do not fit well with Indian perspectives, where patients, a large number of them would be having other comorbidities. They would prefer to pass stool daily, whereas as per the books guidelines and the Bristol charts, they would not agree that they are not constipated. For them, if they've not passed stool every day, they would say, Doctor Saab, constipation hai, ठीक करो, कुछ ना कुछ तो
I
लेना
understand.
पड़ेगा.
I think everybody of us should have a Bristol chart in our OPD, and one should display it on your table. So one should ask what type of stool you pass. You type 1, 2, or 3, or 4. So whatever type. There are certain patients who say sometimes they pass 2, sometimes they pass 6, sometimes they do not know how to pass and what type of structure they pass. So it is okay to understand what the patient perspective is. But if you show this type of chart, then they also feel that you are probably involved in their problems. So this is very important to keep at least a chart within your clinic to decide what type of stool he is passing. I think we go with the third person, what he thinks.
Hello, I'm a gastroenterologist from Nepal. And most of the time what we see is patients have taken all sort of drugs, like they have taken bulk laxatives, lactulose, even Pegleg, like those drugs. So in those cases, what I have seen is they really do well with prokaryotics, colonic prokaryotics, like prucalopride.
Okay.
Those sort of drugs work better. And prucalopride is available in Nepal recently. There are no other drugs we have.
So sometimes we try to use a number of drugs. If the patient has not taken the previous one, we try to add on one more drugs. It is always understand whether the patient is having a IBS-C or it is a chronic idiopathic constipation. There is a slight difference between the two. Though in the clinical practice doesn't matter much, but there are certain drugs which have been approved for IBS-C and there are certain drugs which have been approved for chronic idiopathic constipation. So if the patient has a predominant complaint of pain, that which is associated with defecation and which is relieved with defecation, then probably the pain is an important component of IBS-C. Chronic idiopathic constipation means he's just having no pain and he's still feeling constipation. The other important factor which you told me that try to evaluate your patient if he's not responding. If you're a gastroenterologist, try to see whether he has a normal transit constipation, whether he has a slow transit constipation, or it is a defecatory disorders. So you can do with doing some, maybe you can do a rectal manometry or you do a transient study if you have the facility for that. Most of the tertiary hospital, they have got some markers to see for the transit study and you can go for that. If you go by the definition, the Rome criteria is commonly used for the chronic idiopathic. It should contain all this. I'm not going into the details. And similarly, we should try to divide our patient of constipation, whether they have a normal transit constipation, slow transit constipation, or rectal evacuation disorders. This is very important because if the patient has got a rectal evacuation disorder, which can be picked up if the patient is saying they are using some sort of maneuvers to pass the stool. They are using a digital evacuation, or they press their perineum upwards to pass the stool, or they are using a jet pressure to pass the stool, then it means that probably patient is having a rectal evacuation disorder. Then even if you give any sort of laxative, this patient probably will not respond. Then he requires probably some sort of other things to make out his to treat his constipation. Yeah, doctor, if you wish to say.
What I want to add is there are two scenarios which usually come when this patient come to us. Most of them actually have taken already not only various allopathic but other homeopathic and Ayurvedic preparations also, and they are still on it. So many a times, though we have Bristol chart there in our clinic and all, and it becomes very difficult because daily they are taking habitually all those things, and we do classify them on basis of frequency, consistency, feeling of evacuation and all. So one problem is most of them are already taking either Trifula or other things, है ना? Many of them will be already having melanosis or something, है ना? And the second issue is in our practice, what we do is we first not only take a proper history. Before going and dividing them into these things, we try to see whether they are having any systemic like diabetes, hypothyroidism. Those are also very prominent. Once they are controlled, many of them with simple roughage, lifestyle modification, systemic disorder correction. And after that, yes, we do see whether there is a slow transit or evacuation. We do anorectal manometry, we do MRI deficography, we do all those things. And
Dr. RP, I totally agree with you because when we take the history, it's always better to take the history of your other comorbid conditions and whatever drugs they are taking. It may be quite be possible that you may be taking some sort of drugs which are trying to slow down the transit study.
Yeah, many of them are taking antipsychotics also along
Definitely.
with.
This is an important step. One should always consider that.
It's very difficult to classify them on Bristol because they're already taking antipsychotic. They are taking for 10 years long. And
most of them are multiple drugs. They have multiple comorbidities. They are obese. They are diabetic. They have other problems. So one should always see which type of patient you are dealing with. Now we go for the other. Yeah.
Yes, as a physician, I would like to add that going back to history, many times the patient who are coming to us with constipation are not actually complaining of constipation. What happens to me, out of 10 patients who are coming, only 1 or 2 are complaining of the constipation, but out of the other 7 or 8, when I ask leading questions, they say I have bloating, abdominal fullness, I am having heartburn and all these symptoms. When I ask them, are you able to pass stool easily? Do you need to strain? Do I have hard feces? Then 7 out of those, 60-70% agree, yes, doctor, this is our complaint. I ask them, why did you not tell them
I totally
before?
agree because
The
most of
leading
the
question is
patients
also very important in my view.
most of the patients who have got functional disorder, they have functional disorder which is of the upper GI tract, the lower GI tract, and there may be a combination of both. It's always better to tackle both the condition because even if you tackle the constipation part, if they are not satisfied with their bloating and other parts, they will never be satisfied. Now, please, next. Any your experience, but how do you treat your constipated patient?
So I'll take detailed history. Likewise, all told diabetes, hypothyroidism, and any surgical history because many people, many issues, especially females, they have multiple surgeries in the form of hysterectomy. We see many colonoscopy. We find very difficulty to negotiate the sigmoid colon because of some adhesions and all.
In your clinical practice, how many patients of, if you consider the gender, whether the males are predominant or the females are predominant?
I think both are equal, but the surgical history is also important. Those patients who are having abdominal surgery.
I think in our clinical practice we see both males and females to the equal component. Though in majority of the studies they show the males have the predominant constipation complaint. Yes.
I'm Dr. Asmu Khora. I'm a surgeon. See, so many patients comes with a standard label as IBS constipation or chronic constipation. But one thing I've noticed in my practice that if the patients in last 2 years colonoscopy has not been done or recent colonoscopy, though is being a label as a idiopathic or constipation or chronic constipation, I would like to go for colonoscopy because few of patients, those who are having a chronic constipation for years to come, And people are saying that though previous 2 years colonoscopy is normal, might be having as well in colon. So I do not forget to see that without going for that. If the colonoscopy has not been done in recent past, in spite the patient has been labeled, I will go for it.
I think, and we can have a debate on that, whether all the patient of constipation should have a colonoscopy or not. But if the patient is not having any alarming symptoms, and we are saying that he's having constipation for the last 10 years, 15 years, this is very unlikely that he will have something which is normally picked up in colonoscopy. But you can depend upon the situation. How do you feel that you can go for the colonoscopy? But most of the time they go for colonoscopy single time. Next year they go to another gastroenterologist, maybe some surgeon restro. They get another colonoscopy. Then they can have a 4 or 5 colonoscopies. But per rectal examination is a must for any patient who come to you with a constipation, because it can pick up many things. If you go by the malignancies are most common in Indian scenario at the rectosigmoid junction. So you can do a per rectal examination, that is sufficient. Colonoscopy, patient has got some alarming symptoms. Patient got a weight loss, sudden blood in the stools, or the sudden change in the pattern of the stool passage. You can try colonoscopy in that particular patient. Sir, please.
I'm Dr. Mukesh from Guwahati. I'm a gastroenterologist. So in my practice, actually, we get lots of patients with constipation. So first, we should understand what the patient mean actually, and we should rule out some organic conditions by doing some routine investigations. And the most important thing is that we are noticing that we always overlook that presence of anorectal dysfunction. So it's a very common, and we are doing anorectal manometry, and we are picking out a lot of cases with anorectal dysfunction. That's also needs to be considered.
So I think this is a very important point. Even a single, even if you do not have the anorectometry, a single balloon expulsion test, which is very simple, you can innovate yourself, is very important test to see for whether the patient has got any rectal dysenergy or not. So, please, sir.
Thank you. I'm Professor S.N. Swami, a physician. Constipation, a patient is coming, then you ask the history. History is very important. Take a drug history. Drug history, if it is opioids and calcium channel blockers, tricyclide antidepressants, or more of calcium. And these things will do concern. And the metabolic causes like diabetes gastroparesis, hypothyroidism, or hypercalcemia. And the neurologic disease like spinal injury, Parkinson's disease, or multiple sclerosis, and the habits. And this thing has to be taken as a history. Then you ask the red flag signs, whether there is a rectal bleeding, or there is irritation, or the severe pain in the abdomen. Then you can go for a digital examination, look up the mass, look up the perineum, and then you can go for the colonoscopy. Then after colonoscopy, if you do not find, because in unexplained weight loss in our physician out OPD, if I find a unexplained weight loss, I have found the older people, they're telling all the reports are normal. Even I am a physician also. I told them do a colonoscopy, and all the patients who are having unexplained weight loss, most of the patients, if all the reports are normal, they have colonic cancer. So that is a very important thing one must take into mind, because many people are not willing for a colonoscopy. That's the thing. They tell, no, do everything non colonoscopy.
So we totally agree. The patient has got any alarming symptom, one should always go for some invasive things, maybe the colonoscopy and whatever test you want. So that is very important. Some patients were not willing for the full colonoscopy. Even a sigmoidoscopy will help a lot of patients, because majority of the malignancy who are presented with constipation and bleeding per rectum, they belong to your left side of your colon.
And also anatomical abnormality may be there, strictures or there polyps are there.
So we have a pediatrician also. So I think that Nishant will tell us something about how do one treat up, because even the adult gastroenterologists sometimes see a pediatric patient with the age group of 5-6. They normally come to you because of other things. So I think he will tell us.
Thank you, Dr. Praveen. I'm a pediatric gastroenterologist, and pediatric constipation is very different from adult constipation in that it's functional constipation, 95% of it. So 3 age groups mainly. The less than 2-year age group are usually the ones suffering from organic constipation like Hirschsprung and other such disorders, and they need to be picked up early and treated. But the largest group is beyond 2 years of age, and most of our patients are actually don't know that they are constipated. the commonest complaint with which they come to a pediatrician or a pediatric gastroenterologist is pain abdomen. So it's usually functional abdominal pain, chronic abdominal pain with which they present, and the commonest underlying mechanism in most of them is usually lack of toilet training and stool withholding behavior. Most of these children in today's day and age living in nuclear families have not yet been toilet trained. They are packed up early morning, sent to school, and they withhold stool in the schools, and they come back home and then they pass stools. So usually it's the stool withholding which leads to constipation, rectal distension, and the functional constipation. And they are treated, the commonest drugs which we use are the polyethylene glycol solutions, which are safest for the child, and we don't prefer stimulant laxatives. There is a subset, nearly 20% of these functional constipation children who would not respond to long-term osmotic laxatives, and these are the ones whom we actually look for in terms of dysenergias or slow transit constipations. So pediatric constipation in that way is different.
Sir, Dr. Chawla or maybe Dr. Saraswat can tell how common is stress in day-to-day clinical practice the patient who presented to us with constipation, and how do we tackle that stress part? It's very important, sir, to understand that most of the patients, they are in stress, the young patients, they are in stress, there are young children who come to us with stress.
You're very right, Praveen, that this is a big problem. You always have to handle stress, and constipation, diarrhea, in all of them, this stress is present. But stress handling is probably not an allopathic entity. So people for stress handling techniques are far better in, say, yoga, in pranayam and other relaxation meditation techniques.
Practical tips for the practicing physicians here, sir.
Would be to ask them to do these things. Okay. Now, on which we are not the experts, but I think there are sufficient data to show that these relaxation techniques can help patients who have significant constipation or whatever functional problems that are stress related.
Okay. Sir, your experience on that constipation.
So I fully agree with all of my colleagues here that a proper history that gives the clue what further we have to do. And second thing is that we should not forget that there may be a neurological issues. Many times the patient has spinal injuries today. There is an increase the road traffic accident. In that way, there may be a trivial injury, but the patient has some neurological symptoms. And second important thing which I want to emphasize here, especially in the elderly females, abnormal perineal descent, that we generally bypass or that we generally. So again, having
so I think now
MRI deficography that helps in abnormal perineal descent, and we should rule out, especially in the female, the obstructive defecation syndrome also.
Totally.
So with that,
I think one thing which has commonly seen by all of us is that probably defecatory disorder has to be evaluated there. Now we are coming with a newer drug in the market which has just been launched, is the Linaclotide, for which we are, I think, sitting here. So Linaclotide, though, is approved by FDA in, I think, in 2012, but it has been launched in India just a few days back. So what does Linaclotide does? It is FDA approved for idiopathic constipation for IBS-C, and it is a guanylate cyclase C agonist. How does it act? It acts both in the small intestine and the large intestine. It is related to the uroguanylin. It is a hormone which is secreted during that when we take some meal, and it acts on the cyclic GMP receptors, which increase the cyclic GMP. Thereby, it enhances CFTR and promotes chloride and bicarbonate in the intestinal lumen, so that there is an increased water in our intestine. This is how does it work. It acts both on the small and then the large intestine. So Linaclotide, it is one thing good about the Linaclotide, it is not systemically absorbed. So whatever you take, that goes into your lumen and pass out through the feces. It is almost 100% safe in your cirrhotic patient, it is safe in your CKD patient, it is safe in your CHF patient, it is safe in your diabetic patient. So safety has been approved in majority of the comorbid conditions. So you can give it any patient without any drug-to-drug interaction. How one should give it? It should be taken about 30 minutes prior to your meal, so that it's synchronized with the meals with the action of guanylin, which is secreted about 30 to 40 minutes after meal. So once the patient has taken an Linaclotide, it acts on the GC receptor. It increases both the intracellular cyclic GMP and pericellular cyclic GMP also. How does it act? It causes CFTR activation, thereby it increases chloride and bicarbonate in the lumen. So this is how it works. It also acts on the colonic nociceptor, so the pain associated with constipation also get relieved. So this is good in this particular drug is that it improves constipation as well as decreases the colonic pain.
Especially in IBS.
Especially in IBS patients. So
IBS-C.
Linaclotide is already available in the market. If you compare both Linaclotide with the Pancreatico, it is almost the same, but Linaclotide acts both in the small intestine as well as in the large intestine, whereas the Pancreatico acts only in the small intestine. This is only the difference, and there is some cost difference because Pancreatico is quite costly, and it is half the cost of Linaclotide. So there are multiple trials. I'm not going to trial because this has been FDA approved and we are shortage of time, but it has been shown that it improves complete small bowel movement and spontaneous small bowel movement. Though there is some difference between the complete small bowel movement and the small bowel movement. What does it mean? It means that once the patient has a good satisfaction of that he has passed complete amount of stool, it is called as complete small bowel movement. When the patient he is passing stool but he is not that much satisfied, in clinical trials it is known as spontaneous bowel movement. So it is always better to have complete small bowel movement, which Linaclotide is good at it. So there are a number of trials which have shown it improves the consistency of the a stool. I just skip that because majority of the studies which are on any sort of laxative, they have option whether it is causing spontaneous bowel movements. When we say spontaneous bowel movement, it also means that the patient has not taken any rescue therapy prior to the drug intake. Suppose if I have taken Dulcolax maybe 24 hours prior to, I am not passing any stool, I am taking Dulcoflex and now I am passing a stool, it doesn't corroborate with the spontaneous small bowel movement. So this is in various trials, it is spontaneous bowel movement means. So it has shown that it is good for idiopathic constipation, it has been approved for that, it is good for IBS-C, and there are certain, if you go by the side effects, it doesn't cause majority of, there is no very much of adverse event except for the diarrhea in few patients. There are multiple global trials on constipation, IBS constipation, which has shown that it improves spontaneous bowel movements in majority of the studies compared to the placebo. And it also improves the stool consistency. The complete small bowel movement is also improved. If you go by, there are certain Indian data also which has also shown the same guidelines, the same result. The guideline shows that Linaclotide is approved for IBS-C and it has got a strong recommendation. And if you go by the evidence, there is a high recommendation because there is a lot of RCT in that, and there is even the meta-analysis approved for this. The ECG also suggests that in patient who have and got idiopathic constipation or IBS-C, Linaclotide is the drug of choice after you have used osmotic agents. There are certain studies from India also which have shown the same result as per the Western criteria. So it is being studied in Indian patient also and has shown the same result. I just skip this. Yeah. Yes. So dose is, for patient who has got an idiopathic IBS-C, the dose is being used for more than 200 microgram. It is in India, it has just been launched in two formulations, one is 72 and 145. 72, ideally one should use it with 72 if the patient is not obese and is about 60 to 80 kg of weight. If the patient has got no response, you can increase to 145 microgram. This is a two combination which has now been approved for Indian use. For patient who has got an IBS-C, that dose is almost double. That is, you should use more than 200, maybe
290,
combination of 145 plus.
It is 290.
290, yeah. Ideally, it is 290 if you go by that. But in India, it is not been there, so I'm not talking about that.
It is only April 21st, 2025 it has been approved.
Yeah.
And it doesn't work immediately. It takes a week to 10 days
Sir,
to get the effect.
Majority of that, no, there are many drugs which have now come in the market like Linaclotide, maybe Alopecia. You said everything is good alone, but majority of the drugs, the drugs probably should be used with some sort of osmotic laxative. This is my personal experience, but you can have your own assessment.
If there is diarrhea is a side effect. If the diarrhea, you can reduce the dose because in the chronic constipation, the dose is 145, or for IBS it is 290. But suppose the person, the side effect is diarrhea and is elderly or somebody, they are having dehydration and all that, you can reduce the dose to 72. Even also in children, 6 to 17 years, you can give 72
It has, it
dose.
has not been approved for less than 2 years.
Not
so it
less
should
than
not
2
be
years,
used. Yeah.
because
It
it
should
is
be used after.
a lot of diarrhea and dehydration in the child. Therefore, it is banned. It's contraindicated beyond 2 years, below 2 years.
My experience is that better if we give 60 minutes before meal.
It's
rather
always,
than
it should
30.
be given. It should
No,
be given.
30 minutes it is given, but the as sir has said that if we give 30 minutes, it takes 3, 4, 5 days. If we give 60 minutes, sometimes it acts within 2 days. The first satisfactory moment will be there.
So it has just been launched.
That is
I
what
think
my
everybody has
experience.
his own experience.
My
when they will
experience,
take it
because I used before that from foreign company also, and this is my experience after.
It is more than 30 minutes. You can give 60 minutes, no problem. But minimum is 30 minutes before. That's the thing.
So thank you, panelists. So I think by this we close our first lunch symposium. We have a second one also. So we just need to go up.
So lunch is on.
Thank you very much.
Those who haven't yet taken their lunch can go to the. So for second symposium, emerging pharmacotherapy for MAFLD, Nor-UDCA. The moderator for this session is Dr. Deepak K. Agarwal, and the panelists are Dr. Anant Kumar Singh, Dr. Anil Kumar Sharma, Dr. Chatura L. Priyaratna, Dr. Jay Bhatt, Dr. Kapendra Amate, Dr. Kiran Kumar Khanal, Dr. M.K. Arora, Dr. Mahendra B. Narwaria, Dr. Mahua Mittal, Dr. Mandeep K. Gill, Dr. Manohar Lal Prasad, Dr. M. Sunil Chakravarti, Dr. Niyanta Devi Karki, Dr. Prashish Asadir, Dr. Rabin Hamal, Dr. Ravi Kiran, Dr. Ravi Sahai, Dr. Sanjeet Karki, Dr. Sayantan Dev Sarkar, Dr. Shekhar Podel, Dr. Sudipto Chakravarti, and Dr. Sunil Kumar Kejriwal.
Good afternoon, everyone. Today we'll be discussing of the drug treatment of metabolic dysfunction as well as fatty liver disease, that is MAFLD. Previously used to called as NAFLD. As we know, the MAFLD is liver disorder caused by accumulation or excessive fat in the liver cell, not necessarily caused by the cigarette and alcohol consumption. It encompasses a spectrum of liver abnormalities ranging from a simple steatosis to liver cirrhosis. It can have a simple steatosis, we can have a hepatitis, or we can develop a cirrhosis or hepatocellular carcinoma, and is usually in our country we define by the fibroscan. And early fibrosis is F0, F1, advanced fibrosis F2, F3, and severe fibrosis is cirrhosis, that is F4 fibrosis. And we have defined the severity of the fibrosis fibroscan. And low is the KPA score is less than 7.5, and the height is more than 7.5. Coming to the management of the MAFLD, as far as we know, the lifestyle changes in the mainstay of treatment of MAFLD because related to obesity and lifestyle, the dietary changes. But along with if you have a liver cirrhosis, the complications have to manage by the complication understand liver disease. Then we have liver-directed pharmacotherapy because the 12 to 40% of the NAFLD will progress to hepatitis and cirrhosis. Then we have to target the components of metabolic syndrome like obesity and diabetes, and then lifestyle modifications. The various lifestyle modification remains the key of the treatment. Abstain from alcohol, immunization for hepatitis B, A, modifying the risk factors like hypertension, hyperlipidemia. We have very healthy dietary recommendation like balanced micronutrients, healthy fats, high fiber diet, portion control, low carb, low calorie diet, limited added sugars, and well hydration. And these type of therapy leads to various pharmacokinetic changes, and we see the free fatty acids, the main circulating agent, which are lipotoxic, lead to hepatocellular injury. And this is we have to prevent the hepatocellular injury by preventing these parameters. The variants which are available in the market are the most common we are using now is saroglitazole, which comes with the name of lipaglyn or Belispa. It was approved in India in 2019, and the indication remains non-cirrhotic MASH and MAFLD. Now we are recently going to discuss with the Nor-UDCA, which is recently approved 2025. The launch is still pending. The indication remains the non-cirrhotic and FLD. We have resmetirom, which is approved by the FDA 2024, is still not available in India, and recently approved the semaglutide by US FDA and recently, but now it's available in India as well. Now we have a brief discussion about the Nor-UDCA. The Nor-UDCA is a synthetic bile acid derivative with a shorter side chain than UDCA, and the salient features include is a resistance to amidation, enabling cholestatic shunting, the better hepatic arrangement, more hydrophilic, less cell membrane disruption and toxicity, and the enhanced bile detoxification. It is all related to prevention of the hepatocellular injury. Nor-UDCA causes decreased TGF beta emission and decreased collagen type 1 emission. Increases the FXR. This all leads to decreased inflammation, steatosis, and fibrosis, and indirectly helps in the prevention of FALD-related complications. We have a trial done by Shilpa Medicare. We have 165 patients, and there were two arms, 110 patients with Nor-UDCA, 50 mg daily, and the arm of placebo, 55 patients. They have assessed is 6, 12 weeks, 18, 24 weeks. Eligibility criteria remains NFLT diagnosed FibroScan, and stage remains F2, F3 fibrosis. ALT level more than 1.5 but less than 4 times, and willing to maintain a stable diet, including no alcohol intake throughout the study. And they were assessed if 12 weeks and 24 weeks, and the endpoint remains the normalization of the ALT levels and decrease in the fibrosis by FibroScan. This again, fibrosis score was 7.5 to 14, BMI was less than 35, abnormality AST, divided two groups, and assessed 12 weeks and 24 weeks. And these were the result of the study. The fibrosis, as we know, is the most important prognostic factor in NAFLD, and reflects the hepatic fibrosis, non-invasive method, equivalent to liver biopsy, and represent the entire liver. And with the results of non-UDCA versus placebo, there is a significant reduction in fibrosis at 12 weeks and 24 weeks. And then we assess the control attenuation parameter, that is consumption of the fat in the liver. Again, there is a significant decrease in parameter at 12 weeks and 24 weeks. Then again, the ALT levels, again at 6 weeks, 12 weeks, 18, 25 weeks, the significant reduction in ALT levels after Nor-UDCA. Same day, the ST levels, again the 6 weeks, 12 weeks, 18 and 24 days, the significant reduction in all these levels after Nor-UDCA. Their secondary endpoints also decrease in lipid observed in this study, although there were no change in HbA1c level and the body weight. There were no serious side effects were noted. The only side effect noted were GI side effects, and because the statins were restricted in study, there were dyslipidemia events already there. All adverse events in the study were resolved, and there is no sequelae to that. As I mentioned, there were only minimum side effects, and most of the side effects are related to the GI, and without any eventuality. Once we compare the Nor-UDCA versus UDCA, is a side chain short derivative of UDCA and relative resistance to amidation, which enables it to cholesterol shunting. It decreases the expression of transformative growth factor and collagen type 1, and it decreases fibrosis. It's a significant longer duration of action at 72 hours as compared to 24 by UDCA. And if we see the study, what is the effect of UDCA versus Nor-UDCA? There is no change on ALT level, fibroscan level, and fibrosis stage after 72 weeks of UDCA. But you see Nor-UDCA, there is baseline reduction in the ALT, normalization, fibrosis score after Nor-UDCA. The other drug was siraglutide, which most of us are using. And if you see, as I mentioned, Nor-UDCA, there is a significant reduction in ALT level and fibrosis score after Nor-UDCA. Same with the siraglutide, and ALT levels are normalized. All the patients, the fibrosis significant decrease F2, F3, and essentially most of the fibrosis there is the MRI. So if you see Nor-UDCA versus siraglutide, there was significant reduction in the ALT levels and fibrosis score. The another study which again says ALT, AST level, fibrosis level, and CAP score all were decreased by Nor-UDCA and siraglutide. But if you see HbA1c levels, they are not decreased in Nor-UDCA, but it decreased in siraglutide. Again, another study, we see Nor-UDCA reduction in ALT level, AST level, and CAP score. And CAP score is also significantly reduced in siraglutide. Then another study of siraglutide in metabolic dysfunction. At 72 weeks, there was 62.9% patients saw resolution of steatohepatitis without worsening fibrosis. Fibrosis improvement was observed in a significant higher number of patients. A combined effect of MASH resolution and fibrosis observed in 32% as compared to 16%. And mean body weight also dropped for 10.5% semaglutide patient versus placebo. So semaglutide have decreased ALT, decreased fibrosis, decreased HbA1c, and decreased weight loss, while the UTCA has decreased ALT level, AST level, and fibrosis and CAP score. With Nor-UDCA, there were no change in weight as well as no change in the HbA1c levels. The other drug is resmetirom, and this is not available in India. And trial has shown that it's caused a NASH resolution with no worsening fibrosis in 25.9% patient in 100 milligram versus 9% placebo. And the significant fibrosis improvement was observed in 24.2% patient and 25.9%. In the conclusion, we can say the Nor-UDCA has proven efficacy in safety in MAFLD patient in phase 3 trials. Improvement of the fibroscan level, both fibrosis and CAP score. There is a biochemical improvement, ALT level normalized, and definitely decrease in progression of disease. And it has established safety and tolerance long-term use. It is highlight the potential Nor-UDCA promising treatment management of NAFLD. And this drug is still not available, and I think by the next month is going to be launched. Thank you.
My question is, there are 3 drugs in this group: UDCA, obeticholic acid, and this new one.
Yes.
When obeticholic acid came, it was said that in fibrotic component that is better. Now this is coming. How you compare this with obeticholic acid?
This drug only the recent trial taken is not available in the market. Internationally also is not been launched. So you have to see the result and how it's going to perform.
So the problem would be the dependency of only the fibroscan in this study. What you showed, the Nor-UDCA, it's phase 3 trial. They are giving this medicine for people whom they have diagnosed fibrosis only on fibroscan.
Yes.
How good are we to take that on the face value?
Only this if because most of them you are using fibroscan, we are not using MRI
Most,
also
yeah,
for
but most other studies which are like well published, they have used either biopsy or the MRI.
Yeah, I agree. This the cyclotazar and semaglutide, they are more study based on, because in the US still the fibroscan is still not recognized as method of measuring fibrosis. So there the studies are there with biopsy or MRI, but here we are doing only with the fibroscan.
So this is particularly true because fibroscan per se is very variable. I mean, the results can vary even within minutes or within hours. If you take the two scores simultaneously, they can vary. So how can this be taken as the only guideline deciding
that is
improvement
true.
in
That study is not able to compare the MRI, biopsy, and fibroscan, but this is based only on the fibroscan.
Just wanted to ask one more thing. One of the most commonly used medicines, which is not included in this, is vitamin E, which has traditionally been used for quite some time. So, how would you compare results of vitamin E with this Nor-UDCA?
Because vitamin E definitely sometimes decreases the LT levels, but not definitely the fibrosis. So, although there is no comparative study as well.
Sir, I'm the bariatric surgeon, so my concern is weight loss. So can we combine this with any weight loss medicine which we can prescribe?
Recently, the semaglutide has
GLP-1.
been approved for MAFLD, and I think that will be the wonder drug because it will definitely decrease the weight loss, normalize the LT level as well as decrease the fibrosis. So it may not require the combining of two drugs at all.
Because the newer medicines are once a week, so I think
yes,
we can definitely give.
But in practice, because a lot of diabetic patients have been prescribing semaglutide versus the oral medicine, so willingness and affordability and long-term use, we don't know. So still majority are using semaglutide at present for using MFL, and only few percent are being semaglutide has been used. So we have to see for long term what we are going to do semaglutide versus Nor-UDCA.
So, any idea about the affordability of this medicine, the cost, the price point at which this would be launched?
Still no. When Shilpa Medical can tell us about going the price out, we still don't know.
Can we add this drug to the other with the other?
Pardon?
Can we add this to the other molecule?
Yeah, but say if for this as well as the MAFLD is concerned, this alone is decreasing the LT levels and normalizing the fibrosis, but it's not causing weight reduction and control of sugar. So for weight reduction, we have to choose other drug. Otherwise, normalizing the LT.
Up to F3, F2, up to which level these drugs would be used?
F2, F3 only.
F2, F3.
Yes.
I think whatever the evidence is coming, if we are excluding the caste limitation, semaglutide is going to be proven as a wonder drug for taking the whole care of the patient, like diabetes, obesity, and the action over the anti-lipid action also.
But sir, the problem with semaglutide is that once you stop it, you will regain weight, and that is mainly the fat regain, where that may worsen the NFLD because all these medicines will suppress the appetite. You can't take even protein. So sarcopenia is a new thing which will be coming up now. So we may need something which can cater, or we can treat the sarcopenia, because muscle loss. So overall, if you look at the percentage of fat, there will be more fat, muscle loss and fat loss. But when they regain, there is more fat gain, not the muscle gain. So percentage wise, the fat will be more.
When we are talking of lifestyle changes, the Mediterranean diet is very important. High protein, greens, and weight training with all the drugs at all. To maintain the muscle mass, we have to do the weight training as well.
But in India, because it's an uncontrolled market, I think people keep giving it to each other. So very difficult to control these medicines.
Good lifestyle changes you can control without drugs also. So.
GI upset is also a problem with SEMA. GI upset.
Thank you.
Thank you, sir. Thank you. It's a great discussion. Thank you.
Thank you.